and we get to talk about my favorite system, which is the cardiovascular system. And this is chapter 12. So let's get started. So, cardiovascular obviously makes us stay alive because it's our heart pumping blood everywhere so that we can, you know, do fun things like, hug our friends and ride horses and all that fun stuff. So first, a quick overall review. The circulatory system is composed of vessels, fluid, as well as the main central pump. And the blood is going to flow from the systemic to the pulmonary, back to the systemic circulation. So a lot of people, like before they're educated, think that the heart's kind of like a closed system. But once you realize that you actually have to throw the respiratory system in there too for oxygen exchange, it makes it so much cooler, right? So it's not just in the heart. So like, we'll see, but it goes from the right side of the heart and then it pumps through the whole lungs, right? And does the oxygen exchange and the capillaries and the arterioles, no, the bronchioles and the little alveoli of the lungs, and then it comes back into the left side of the heart and then it gets pumped through your whole body. So it's so cool because it incorporates not only just the veins, but you actually have to incorporate the respiratory system. So for a little bit about anatomy, it's located in the mediastinum. And so the heart itself is located within the pericardial sac, and there is the parietal pericardium, the epicardium, and the pericardial cavity, the myocardium, and the endocardium. So, all of these are just the different layers that help to protect, the heart, etc., and make sure that it's not going anywhere. Okay, you have your heart valves, which is your arterial ventricle valves, and also you have your semilunar valves, and then you have the septum. And so we'll go into these in a little bit more detail, but this is just the general overall anatomy. So when you're talking about the conduction system, which basically is what the heart is, there is the conduction pathway, and this starts at the SA node, okay? And that's the sinoatrial node. And so things are named for what they do. So the SA node is a sinoatrial node, and this is basically the pacemaker of the body. And so it's going to tell your heart when to start a beat, right? And this is what controls the sinus rhythm of the heart. Then you have your AV node. And so if you think of, again, what it's named for in the anatomy, atrioventricular. So this is the node or the spot that is going to connect the atria with the ventricle. So AV, atrioventricular, right? And so this is located in the floor of the right atrium. Then you also have your AV bundle, and this is commonly called the bundle of His. And this has your right and your left branches. And this is what branches out those electrical signals in our heart. And then we also have Purkinje fibers, which is like a very fun word to say. And these are our terminal fibers that carry out the contraction and the signal. So when you look at an EEG, okay, this is what we're going to be looking for. And the ECG is the electrocardiogram. ECG. I said EEG before, but I meant ECG. And we're looking for the P wave, and the P wave is going to denote the depolarization of the atria. Then you have your QRS wave, and this is going to represent the depolarization of ventricles. Then you also have your T wave, and this is going to be representing the repolarization of the ventricles. Okay, so all of the different beats have a function. And so this is figure 12.2 in your book on page 225. And so this is a drawing of the conduction system of the heart. So an impulse is normally going to be generated in the sinus node, and then it goes and it travels down to the AV node, and then it goes to the bundle of His, and then through the Purkinje fibers, and then to the myocardium, the ventricular myocardium. And then over here, you can have the recording of the depolarization and the repolarization event currents in the heart with the electrodes on the surface of the body. And this is going to be producing the characteristic waves that we are looking at. And so down here in black, you can see this is going to be the atrial excitation, where the red is the excitation of the ventricles. That's going to begin with an initial downward deflection, and this is called the Q. And then the R and the S is going to be the actual contraction and the beat, and then, recovery. So how do we control the heart? Well, the cardiac control center is located in the medulla oblongata of your brain, right? So close to your brainstem area. So this is going to control the rate and the force of contraction, and this is located in the medulla. And these have baroreceptors. And so think of barometric pressure. Okay, this is like a pressure differentiation. And so those baroreceptors are going to detect the changes in blood pressure. And these are located in the aorta and the internal carotid arteries. And so we can like determine the pressure of what's going on in all over, the blood vessels and the heart, etc. And then we also have sympathetic stimulation, and this is through the cardiac accelerator nerve. And this is what's going to increase our heart rate, which can potentially cause a tachycardia if it goes too fast. Then you also have the parasympathetic stimulation, and this comes from the cranial nerve 10, which is also known as the vagus nerve. And this is what's going to be reacting to decrease that heart rate, which is called bradykinesia. So there's a couple different factors that are going to be controlling the heart rate. And so these are all, of course, very, very important. I'm trying to figure out on which page you have these on there. So basically, if you have increased thyroid hormones or epinephrine, this can cause it to stimulate and get a little bit faster. Elevated body temperature can denote that you have an infection, like an example of fever. So your body might have an increased cardiac rate because of that. Also, increased environmental temperatures, especially in higher humidities. This can cause you to have a higher heart rate. Okay, exercising, smoking, stress response. I'm always like stressed to the gills, and so I have to be careful to keep my heart rate and my blood pressure down, right? And then pregnancy, because you're increasing your blood flow capacity by at least a third, if not more. And then also pain can cause you to have an increased heart rate. So, talking about coronary circulation, well, you have your right and your left coronary arteries. And the branch of the aorta immediately is distal to the aortic valve, and this is part of the systemic circulation. And then the left coronary artery is going to divide into the left anterior descending, or the intraventricular artery, and then also the left circumflex artery. So just some of your anatomy to review from A&P. The right coronary artery is then going to branch, and it's going to become into the right marginal artery as well as the posterior intraventricular artery. And many small branches extend from these arteries to supply the myocardium and the endocardium. And collateral circulation in this instance is extremely limited. So looking at your coronary arteries, you can see this fun little shop. So let me pause for a second so I can't see this exact figure in your book. So this must be from a previous version. But basically what we're going to be looking at, the arteries can be seen in figure 12.3. So this is, again, just showing you the anatomy of what we're talking about. And what these two pictures are showing you is the direction of the blood flow. Okay, so when we contract, the ventricular contraction, the aortic valve is going to be open, and this is going to allow the blood flow to go through it. And this is the aortic valve, again, showing that it's open in this area, where if you compare it to this one, it's going to be closed. And you have your blood supply feeding in the right coronary artery as well as the left coronary artery. So again, this is when you have the bottom chamber, the ventricle of your heart, contracting and pushing blood to either lungs if it's the right, or the rest of the body if it's your left ventricle. And then when we have the ventricular relaxation, which we need to allow it to refill, then we have the backflow of blood that's going to close that valve, and it's going to fill the coronary arteries. So it's kind of like, if you have a balloon, we squish it all out, right, during the contraction, and then we have to allow it to relax in order to fill up again. That was a very loud clap, sorry. And then this blood flow is going to go into the myocardium. Okay, so basically, this is showing you what's happening to the aortic valve during the contraction to allow the blood flow out, and then to refill in that area. Okay. So the cardiac cycle is very important, and there's a great figure on It's on page 227, figure 12.4, and it describes each of these in picture form. Okay, and that's coming up in 3 slides, but if you want to turn to that while I'm talking about it, you're more than welcome to do that too. So the diastole, this is where we have the relaxation of that myocardial muscle, and this is required to allow those chambers to fill. Then you have your systole, and this is where we have the contraction of the myocardial muscles, and those are going to that is going to provide an increase in pressure in order to eject the blood and make it go to the body. The cycle is going to begin again with the atria, which is that top chamber. So when one of my doctors kind of described this as a house, right? It's a 4-bedroom house. And so I know I'm backwards right now so that you can't quite, I know it's kind of like silly over here. But anyway, if you have like a house, right? So let's see if I can draw backwards. So you have a house like this, right? And then if you divide it into 4 rooms, your upper right is actually here because it's anatomical, right? So even though this looks like it's left to you, this is the right side of my body. So you have your right atria, and then you have your right ventricle, right? And then you have your left atria, and then you have your left ventricle. So just kind of think of them as 4 rooms, and then there's like a chimney. And so when you have the right ventricle, it's going to go up here into like your lungs. And then when it's reoxygenated, it's going to come back into the left atria. So you can kind of think of it as like a 4-bedroom house if you want to, if you're that house. Anyway, so the systole is going to be the contraction that is going to cause the increased pressure to eject that blood to the next room. And then the cycle begins with the atria being relaxed, filling with blood. Then the AV valves are going to open, the blood is going to flow into the ventricles, the atria is going to contract, and this is going to remain, and then the remaining blood is going to be forced into the ventricles. The atria is then going to relax, and then the ventricles contract, and then it goes to the AV valves, and they're going to close, and then the semilunar valves are going to open, and then the blood goes into the aorta and the pulmonary artery, and then the ventricles are going to relax, and then it just keeps going around. So the lub-dub. Okay, this is because the lub is what you can actually hear the closure of the AV valves. And so that's pretty cool. And then the dub is going to be the closure of the semilunar valves. And so kind of pull up, pictures of or videos. Let's see if I can pull one up on YouTube loud enough for you guys to listen to. And you can see what's going on. So, heart sounds. Let's see if
sometimes choosing me means using the limited time I have and making the most of it.
Commercials. Gotta love commercials.
When a healthy heart beats, it makes a lub-dub sound. The first heart sound, lub, also known as S1, is caused by the closing of the AV valves after the atria have pumped blood into the ventricles. The second heart sound, dub, or S2, originates from the closing of the aortic and pulmonary valves, right after the ventricles have ejected the blood. The time interval between S1 and S2 is when the ventricles contract, called systole. The interval between S2 and the next S1 is when the ventricles relax and are filled with blood, called diastole. Diastole is longer than systole, hence the lub-dub, lub-dub, lub-dub. Heart sounds are auscultated at 4 different sites on the chest wall, which correspond to the location of blood flow as it passes through the aortic, pulmonic, tricuspid, and mitral valves, respectively. This is how similar defects associated with different valves are differentiated. Heart.
So, kind of fun. All right, and then those murmurs, actually, I like that video. I'm probably going to send it out to you. The murmurs are going to be caused by the incompetent valves, so valves that aren't quite functioning the way that they're supposed to be. And a pulse is going to indicate your heart rate, where a pulse deficit is going to be the difference in the rate between the apical and the radial pulses. So here is a fun picture for pulse points, and this is figure 12.5 in your book on page 228. And so this again is going to be just the location of commonly used pulse points, and each pulse point is going to be named after the artery that it's associated with. So you have the facial artery, the branchial artery, the radial artery, the popliteal artery, the dorsalis pedis artery, so like in your ankle, right? Your femoral artery, your axillary artery, common carotid, which is the one we usually do when you do that, and then the temporal artery when you have a migraine and you can feel it go la 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 la, right? Promise I haven't had caffeine today, guys. This is just me. All right, so this is that cardiac cycle that I was talking about, and this is on page 227, and this is figure 12.4. And so here in that video, actually did a great job explaining it too. In diastole, the atria here is going to fill and all the valves are closed. And then in diastole, this is going to be increased atrial pressure that's going to open those AV valves, and it's going to allow the ventricles to fill. And then systole begins, and the atria contracts and it empties into, the atria contracts and empties, and this is when the ventricles are going to be full. And then in diastole, the ventricles are empty, the ventricles are going to relax, and the aortic and pulmonary valves are going to close. Oh, dude, I totally just read. I'm like, why did that go the wrong way? Rewind. Okay, so here systole begins, the atria contracts and empties, ventricles are full, and then it goes down here to 4, and then this is where the ventricles begin to contract, and the pressure closes the AV valves, and it causes the atria to relax. And then here in step 5, you have systole, and this is where the ventricles contract, and you have increased pressure that's occurring in the ventricles. The aortic and pulmonary valves are going to be open, and the blood is going to be injected into the aorta and the pulmonary artery. And then here in 6 is going to be diastole, and this is where the ventricles are empty. Then the ventricles are going to relax, and the aortic and pulmonary valves are going to close. And then it just repeats 1 through 6, 1 through 6, and this is the cycle. And it's again very cool. And I don't know, I love to experiment on people, not in a Frankenstein way. But like, if there's somebody here, listen to their heart. If you're very close to them, put your head up to their chest and just kind of close your eyes and, listen to it. Or if you have a stethoscope, that'd be great too. But just kind of listen to it and just be amazed in the beauty of your body. Okay. So what about cardiac function? Well, there's a couple of abbreviations that you're going to need to know here. And cardiac output is going to be CO. And this is the blood that's ejected by a ventricle in 1 minute. So how to calculate it is going to be the cardiac output is equivalent to the stroke volume times the heart rate. So then what is the stroke volume? Well, this is the volume of blood that's going to be pumped out of that ventricle per contraction. We also have preload, and this is the amount of blood that's delivered to the heart by the venous return. We also have afterload, and this is the force that's required to eject blood from the ventricles. And this is determined by the peripheral resistance in the arteries. Okay, so then if you get like arteriosclerosis, you have like stiff veins and stuff, then it'll show up here. So what about your blood pressure, the two values, right? Well, you have systolic over diastolic. So the systolic pressure, this is the exerted pressure when blood is ejected from the ventricles. And this is the higher number. And then you have the diastolic pressure, and this is sustained pressure when the ventricles relax. And this is lower. And so blood pressure is altered by cardiac output, blood volume, and peripheral resistance. Okay. So I think, what is it? Normal is 120 over 80, right? So then the systolic would be the 120, and that would be exerted when the it's like how much pressure it takes for you to like squirt ketchup out of a bottle. That would be the systolic pressure, right? And then the diastolic is when it's kind of filling back up and you're not pushing on it. That's the diastolic. And so that kind of shows elasticity in the heart. So it's showing you how strong the heart is and how easily it gets to be refilled, if that makes sense. So I think it's kind of cool your body's just amazing. And again, I should have been a cardiologist or something because I love it. So what about changes in blood pressure? Well, this can be controlled by the sympathetic branch of the autonomic nervous system. If you have an increased output, then that's going to lead to vasoconstriction and increased blood pressure. Where if you have a decreased output, this can lead to vasodilation and decreased blood pressure. The blood pressure is directly proportional to blood volume. And also you have a big hormonal control on your blood pressure. So antidiuretic hormones can increase blood pressure. Um, Aldosterone can increase blood volume and increase blood pressure. Your renin, angiotensin, aldosterone meds can cause vasoconstriction, which can increase blood pressure. So there's times that we want to increase it, and there's times that we want to decrease it, right? So we need to have meds and understanding on how we can do both. So here are some fun little formulas for you guys to understand. And this is on page 229 in your book, figure 12.7. And so this is again showing you your cardiac output, which is the amount of blood pumped by each ventricle in 1 minute, is equal to the heart rate, which is the number of contractions in the ventricles every minute, times the stroke volume, which again, that stroke volume is the amount of blood that's ejected from each ventricle during the contraction. And so there's like on in your book, there's extra explanations underneath. And so there are factors affecting the cardiac output, and then this equals the sympathetic nervous system or the administration of epinephrine. You have your venous return, which is your preload, your contractility, and your afterload. And so I'm trying to like it says, for example, in your book, and so it has like a fun little. I can't read very well backwards, but it has like a fun little description of what things can change. So make sure that you go to again page 229, figure 12.7, because it says blood pressure, no change. It would have like if we have increased cardiac output and a decreased peripheral resistance, then that would lead to no change in blood pressure. Where if you have cardiac output that doesn't have any change and you have increased peripheral resistance, then that would cause your blood pressure to be elevated. And then if you have just it shows you like different ways that you can look at how these numbers can be manipulated. Okay, so make sure that you look at that because it's pretty cool. You change one thing, you're more than likely going to change the other unless it's like the homeostatic balancing type thing. So, okay, getting to the pathophysiology. What about heart disorders? Well, we have diagnostic tests for cardiovascular functions, and these include the electrocardiography. And this is useful in the initial diagnoses and monitoring of the dysrhythmias, also myocardial infarctions, fancy word for heart attacks, infections, and pericarditis. You have vesiculation, and this is where we can determine the valvular, so abnormalities, so the abnormalities in the valves or abnormal shunts of blood that cause murmurs, and this can also be detected by listening through your stethoscope. You have your echocardiography, and this is used to record the heart wave movements, blood flow, and cardiac output, so it's like an ultrasound for your heart. Then you also have cardiac stress tests, and these are used to assess general cardiovascular function. They make you run on a treadmill at different intervals and lengths, and they like are monitoring your heart rate, respiratory rate, a whole bunch of fun stuff. You can also do chest x-rays, and these are used to show the shape and the size of the heart. These are done by either nuclear imaging or tomographic studies. You also have cardiac caths, and these measure the pressure and the assesses the valve and heart function. And these determine the central venous pressure and pulmonary capillary wedge pressure. You also have angiography, and this is the visualization of blood flow in the coronary arteries. So here is a picture of what an angiograph looks like, and this is figure 12.8 in your book on page 231. And so this one where the arrow is showing stenosis. So remember, like stenosis is a narrowing or almost closing of an artery, right? And so that's why you'd put like a stent in it to open it up. So this is specifically the stenosis of the left anterior descending coronary artery. So you can see that obviously if you close off blood flow, that's not very good, right? Because then that part, the part downstream from where that blockage is, isn't going to get blood flow, and that's what causes an MI, and it can cause that tissue to die and not be very good. We also have Doppler studies, and these you kind of do it along when you're getting an echo. And these are going to assess the blood flow in the peripheral vessels, and then also it helps to record the blood flow or the obstructions. And it's really you guys know I have heart problems, and so I have all this stuff done to me. And so I think this is another reason why I love the cardiac event. But anyways, it's kind of like really relaxing to listen to. It's like, so it's kind of cool. I don't know. You also have blood tests, and these can assess the levels of your serum triglycerides, your cholesterol, your sodium, potassium, calcium, and other electrolytes, as well as your arterial blood gas determination. And these are going to help to check the current oxygen levels and acid-base balances in your body. So, what can we do to help keep us healthy? Well, dietary modifications is a big one, and so we want to decrease our total fat intake, and generally reduce any extra weight that we may be carrying, and then also reduce salt intake. So, a little bit of a fun fact: be careful with low fat things because they actually tend to have more sugar. It's true. Look at low fat yogurt versus regular yogurt. The low fat yogurt does have less fat in it, but it has more sugar in it to make up for the lost taste. It's crazy. Anyway, but anytime that you have more weight or you have, you're gonna make your heart work harder to get blood to all the little areas in your body. And then if you have excess salt, it'll cause you to maintain water. Maintaining water is gonna again increase your blood volume, all that jazz. Also, your regular exercise program, this is going to increase our good cholesterol, so our HDL, and lower the bad cholesterol, and then which is the LDL. And then also we can that helps to reduce stress levels. And then stop smoking, guys. It's not good for you in lots of different ways, but this can also reduce the risk of coronary artery disease. So what about pharmacologic therapy, right? So drug therapy. Well, you can be on vasodilators. And again, break it down to those root words. Vaso means vascular, dilators means making them go bigger. And so vasodilators can reduce that peripheral resistance, okay? Beta blockers, this is what we use for the treatment of high blood pressure and dysrhythmias, so crazy heart rates, right? Also, it can reduce angina attacks, which is that crushing muscle pain, but it's not like a heart attack, it's just like muscle. You can also use calcium channel blockers, and these would decrease the cardiac contractility, antihypertensives, and vasodilators, as well as prophylactics against angina, because you want to try to keep people comfy. Digoxin is a common one that they use, and this is used for heart failure, and this is an antidysrhythmic drug for atrial dysrhythmias. So I'm lucky and I have ventricle dysrhythmias, so so mine are the lethal ones. So much fun. So I'm not on digoxin because I don't have problems, knock on wood, with my atria. Antihypertensive drugs, these are used to lower blood pressure. Adrenergic blocking drugs, and these are going to act on the sympathetic nervous system centrally or in the periphery. And then also you have your ACE inhibitors. These are angiotensin converting enzyme, abbreviated as ACE inhibitors. And these are going to block the conversion of angiotensin 1 to angiotensin 2. You can also use diuretics, okay? And these are going to remove excess sodium and or water in your body. And these are used to treat high blood pressure as well as congestive heart failure. You can have anticoagulants, and these are used to reduce the blood clot formation as well as cholesterol lowering drugs. And these help reduce the low density lipoprotein and cholesterol levels. This is a table of selected cardiovascular drugs. This is on page 233 in your book, and it is figure 12.1. So this is a nice little summary to summarize everything that's going on. So what about moving on to coronary artery disease, which is abbreviated CAD, or ischemic heart disease, IHD, or acute coronary syndrome? And this is starting to be discussed on page 233 in your book. So arteriosclerosis, this is a generalized term for all types of different arterial changes. There are degenerative changes in the small arteries and arterioles. They lose elasticity. The lumen, which is the opening, gradually narrows and it may become obstructed. And then this can cause increased blood pressure. You also have arteriosclerosis, and this is presence in the erythromas in the large arteries. And these are the plaques that are consisting of lipids, calcium, and possible clots. And this is mostly related to diet, exercise, and stress levels. So this is figure 12.9 in your book on page 234. And this is a comparison of the normal aorta with a smooth lining and patent openings into the branching arteries, which is going to be the top, so the smooth stuff that you want. And then it's comparing the arteriosclerotic or our aorta, and that's the one down here on the bottom. And so it wants to note the rough surface and the blocked opening to the branches, right? And so treat your body right, guys. You only get one. Okay. So what about lipid transport? Um, so this is, we care about this because lipids are transported with a combination of proteins. So we have LDL and we have HDL. Okay, so our LDL is our low density lipoprotein, and this transports the cholesterol from the liver to the cells. And this is a major factor that contributes to erythroma formation. You also have high density lipoprotein, which is your HDL, and this is going to transport the cholesterol away from the peripheral cells to the liver. And this is the good cholesterol. This is the good lipoprotein. And this aids in the catabolism in the liver as well as secretion. Okay, and catabolism is a catabolic, so that's breaking down. That's the thing. So what about this with lipoproteins, composition, and transports? And so this is figure 12.10 in your book on page 234. And so up here you have a comparison of HDL and LDL. And so again, this HDL is the good, the LDL is the bad. So you can see the good has more protein, less cholesterol, less triglycerides, where the bad guy has a lot of cholesterol, less proteins, and a fair amount of phospholipids. And so down here for the transport of lipids, the dietary intake of cholesterol into triglyceride occurs here in your intestine, and your bile helps to break that down. And then the chylomicrons, which are just kind of like little Pac-Man guys, these are absorbed into the blood and into the lymphatic system. And then the lipid uptake by the adipose and skeletal muscle cells occurs here in step 3. And then in step 4, you have the remnants that is going to transverse or travel to the liver. And then the liver down here is going to make lipoproteins. So synthesizes, obviously, is a fancy word for to make. And then over here in 6, the LDL is going to transport the cholesterol to the cells. And then up here in 7, the LDL attaches to the LDL receptor in the smooth muscle and the endothelial tissue. And then down here in 8, the HDL is going to transport the cholesterol from the cells to the liver. So that's just a nice overview of the transport of the cells. Again, that is figure 12.10 in your book on page 234. So what about risk factors in for arteriosclerosis? Well, some of them are non-modifiable. So we can't control our age, right? Every day we age a little bit more, right? You can't control your gender at birth or your genetic or familiar factors, but you can modify or change some things to help you out. And that would be your weight, if you're exercising or not, if you're a smoker, diabetes from weight, etc. Poorly controlled high blood pressure, and a combination of oral contraceptives, so birth control, and smoking is not necessarily a good thing. So looking at this, you have the progression of arteriosclerosis, and this is on page 236 in your book, figure 12.11. And so up here in A, you can see that this is the damaged endothelium. And so it's the damaged epithelium from the chronic endothelial injury from hypertension, smoking, hyperlipidemia, rheumatic hypodynamic factors, toxins, viruses, etc. Okay, and then this is going to be showing the response to the injury, where you're going to have the damaged endothelium here, and the monocytes coming, etc. And then you have down here in B a fatty streak. So you can see this yellow fatty streak is starting to accumulate. And then it migrates. Down here you can see the migration of the smooth muscle into the intima. And then plaques are going to form up here in C. And this is where it becomes a fibrous plaque. And then it can form a collagen cap, which is that fibrous tissue, also fibroblasts, a fissure in the plaque, right? and then also a lipid pool, which is just pooling of like basically a fat pocket. And then down here you can have a complicated lesion, and this is where you can have a thrombus, so a blood clot, right? The thinning of the collagen cap as well as that fat pool. Okay, so this is again the progression of arteriosclerosis on page 236. So what can we do for diagnostic tests? Well, we can do our serum lipid levels to monitor our LDL and our HDL. You can also do the stress test, and this is going to be screening for arterial obstructions. You can have nuclear medicine studies, and these are going to determine the degree of the tissue perfusion. And then, I mean, so all these things we want to kind of keep an eye on and diagnose as early as we can. And then this is a summary of the consequences of arteriosclerosis, and this is on page 237. And so, in the heart, it can cause coronary arteries to have a partial occlusion, and this can lead to angina pectoris or an ischemic heart disease. It can lead to total occlusion, which can lead to an MI, which is your full-out heart attack, right? Your myocardial infarction. Again, this is all because of narrowing of the large arteries and the cholesterol plaques. So this is clear, partial, total obstruction. What it can affect the brain can cause carotid or cerebral arteries to be partially occluded, which can lead to stroke, TIA. It can lead to total occlusion, which can lead to the cerebral vascular accident or the heart attacks that we talked about the other day. Then it also has effect on the peripheral arteries. If it affects the aorta, it can cause an aneurysm, and this is an occlusion, a rupture, or a hemorrhoid. Uh, Not a hemorrhoid. I think that people would rather take a hemorrhoid over a hemorrhage. Okay, so this is meant to be hemorrhage. And then also you have effects that can happen in your legs, in your iliac arteries. And this is where you have the peripheral vascular disease that can occur, and this can cause gangrene as well as potential amputations. So take care of your blood vessels, guys. Again, treatment, this is discussed on page 236. Sorry, there's like these kittens. One of my friends like is a kitten foster mom, and I have them on YouTube on my computer screen. And so when they move, it catches my attention. Sorry, I should close it. Anyway, so treatment would be weight loss, increased exercise, dietary modification, reduction of the sodium intake, control of hypertension, control of your primary disorder if you can. And then also, stop smoking, take cholesterol meds, and then surgical interventions can also occur to help solve you. So I have to show you guys. Little baby kitties. Hopefully you can see them. So cute. Okay. All right, so what happens for some of these treatments? What about a coronary artery bypass? Well, this is on page 238, figure 12.13. And so this would be what would potentially could happen for a coronary artery bypass graft. And so you can take part of your sphenius vein, and then you're going to take it and have a directional valve rotated upside down, and then you can put it in there and replace the blocked artery, right? So this is insane that they can actually do this. Like, it just boggles my mind. I love medicine. Okay, but this is a picture on page 238. So what about angina? And so this is basically chest pain, and this occurs when there's either a deficit of oxygen there's a deficit of oxygen to the heart muscle. And so basically we don't have enough oxygen to meet what our heart needs. And so the chest pain can occur in different patterns. And so you have either classic or external angina. And then you can also have variant angina, and this is where the vasospasms can occur at rest. You also have unstable angina, and this is where you have prolonged pain at rest, and this may precede the myocardial infarction. Angina pectoris can be recurrent. You can have intermittent brief episodes of substernal chest pain. It can be triggered by physical or emotional stresses. The attacks vary in severity and duration, but they become more frequent and longer as a disease may progress. And also, these can be relieved by rest and also administration of coronary vasodilators, so nitro, right? So they have those tabs that you can put sublingually and they can absorb and help to basically vasodilate, right? So they primarily act in reducing systemic resistance and decreasing demand for oxygen. Signs and symptoms of angina would be pallor, diaphoresis, which is excessive sweating, nausea, as well as chest pain. Looking at this is figure 12.14 on page 239. So this is normal, homeostatic, right? And if you have increased oxygen supply, then you get more oxygen. So this is all good. But sometimes when we have a decreased oxygen supply that is not met, then that can cause pain, and the normal activity can cause myocardial ischemia, or you can have decreased oxygen supply leading to decreased activity, which then can lead to more decreased oxygen supply. Again, you're not getting your needs met, and that can lead to pain, and your basic needs, again, can lead to myocardial ischemia. So what do we do to treat this? Rest and stop the activity. The patient should be seated in an upright position. Also administer nitroglycerin sublingually, so underneath your tongue. Check your pulse and respiration. Administer oxygen if necessary. If the patient is known to have angina, then they could have a secondary dose of nitroglycerin to help. And then if you have a patient without a history of angina, then you need to make sure that they get emergency medical aid. Um, so for myocardial infarction, this can occur when the coronary artery is totally obstructed. Arteriosclerosis is the most common cause, and the thrombus from an artheroma may obstruct the artery. Also, you can have vasospasm that can be caused in a small percentage of people, and the size and location of the infarct is going to determine the amount of damage that occurs. Um, Warning signs of a heart attack is that you can feel pressure, heaviness, or burning of the chest, especially with increased activity. You can have sudden shortness of breath, weakness, and fatigue. This can cause nausea and indigestion, anxiety, and fear, kind of like a panic. And pain may occur, and if present, it is usually a substernal, crushing, and irradiating pain. So this is a picture of an MI and what actually happens. And so this is figure 12.15 in your book on page 240. And so this is showing you the damage that can be caused. Okay, so down here, this one happens to be left anterior ventricular artery. And this is going to be the area of the infarction that's going to cause the necrosis. And then also the thrombolus is going to cause total obstruction of the artery. So basically, this is not a good thing, guys. Looking at the tissue changes here, still in that same figure. This is acute myocardial infarction, the microscopic section of acute myocardial infarct at 48 hours, showing coagulation, necrosis, and maximal neutrophilic infiltrate, and at low and at high power. So you can see that there's a lot of the infiltrate there. So what can we do to test this diagnostically? Well, basically we're going to look for changes in our ECG and also the serum enzyme and isoenzyme levels. The serum levels and the myosin cardiac troponin levels are going to be elevated. You look for leukocytosis, which is elevated. CRP and ESR are common. And also you have the arterial blood gas measurements that can be altered in severe cases. And also you have the pulmonary artery pressure measures that can be helpful. Okay. When you're looking at serum enzyme levels, this is figure 12.16 in your book on page 241. The serum levels, enzymes and isoenzyme levels with myocardial infarction, the abbreviations AST is aspartate aminotransferase, CMK-MB is the creatinine phosphokinase containing M and B subunits, and LDH is the lactate dehydrogenase. So you can see how they rise and fall over, after the infarction. So what can happen with complications of a heart attack? Well, obviously they can cause death. Okay, it can also cause cardiogenic shock, can cause congestive heart failure. It can cause a rupture of the necrotic heart tissue or the cardiac tamponade. You can also have a thromboembolism that causes the cerebrovascular accident, which is again abbreviated CVA, with the left ventricular myocardial infarction. So, how do you treat this? Well, treatments are discussed on page 242. One is reduce your cardiac demand. Two is provide oxygen therapy, analgesics, which are prophylactics, right? Um, and yep, anticoagulants, thrombolytic agents can be used, tissue plasminogen activators, and then also using medications to treat these, including treating your dysrhythmias, your hypertension, your congestive heart failure. Your cardiac rehab should begin immediately. Um, so what about your dysrhythmias and your arrhythmias? So these are when you have any deviation from your normal cardiac rate or rhythm. These can be caused by electrolyte abnormalities, fevers, hypoxia, stress, infection, and drug toxicity. You're going to use an electrocardiography to monitor the conduction systems and also be able to detect abnormalities. You're looking for a reduction in the efficacy of the heart's pumping cycle that would be caused by this, and many types of abnormal conduction patterns do exist. So how do we treat it? Well, determine the cause. That is, you see if it's treatable by drugs, and sometimes if you change the drug dose, that might eliminate dysrhythmias. Unfortunately, we have a lot of things that happen because of drugs, like side effects, right? Also, you can use antiarrhythmic drugs, and these would be like your beta adrenergic blockers, as well as your calcium channel blockers. And this can also include digoxin or the use of a pacemaker. Okay. So here is a picture of a permanent pacemaker implant, and this is on page 12.18 in your book, and this is on page 245. So basically, this is a permanent implant. Pacemakers are permanent when they're, I have one, so that's why I'm pointing. They're under the skin, and then you can either have a 1 lead or a 2 lead, and they're going to either go to the atria or the ventricle or both. I have a 2 lead. Yep. I'm taking vitamin B12 gummies. Sorry, I'm getting tired. All right, what about when we have SA node abnormalities? Well, remember that our SA node is that sinoatrial node, and this is the pacemaker of the heart. And so this can cause a lot of really big problems. And so the rate can be altered. If we have bradycardia, this is regular but slow heart rate. Tachycardia is a regular rapid heart rate. Then you also have sick sinus syndrome. And this is marked by altering bradycardia and tachycardia. And this often requires mechanical pacemakers to help regulate. So here is a picture of some EEGs, strip recordings, so that we can see the differentiations of what's going on when we're looking at our heart, right? So this is on page 243 of your book, figure 12.17. So A here shows normal. B here is going to show AV node block, and it's showing very slow ventricular contractions that are 25 to 45 beats per minute at rest. The P waves are going to be widely spaced and separated from the peaks of the QRS complexes. Down here in C, it shows bradycardia, which is the slow heart rate, which is less than 60 beats per minute. There's no disruption of the normal rhythm pattern. D here shows tachycardia, and this is a rapid heart rate, which is greater than 100 beats per minute with no disruption of normal rhythm pattern. You have NSR, which is normal sinus rhythm, and PAT, which is the proximal or sudden atrial tachycardia. Down here in E, you have premature atrial contractions, or PACs, and this is where you have unexpected early P waves that differ from normal P waves. And the PR interval may be shorter or longer than normal, and you have normal QRS complex, and you have, if you have more than 6 PACs per minute, this may precede atrial fibrillation. Down here in F, you have AFib, which is atrial fibrillation. This is where you have irregular, rapid atrial depolarizations. The P wave is rapid, which is greater than 300 per minute, and irregular with the QRS complexes between 150 to 170 beats per minute. And then finally down here in G, you have ventricular fibrillation, and this is a complete disruption of normal heart rhythm. Okay, no bueno, not very good. All right, so what about some of these atrial abnormalities? Well, we have premature atrial contractions or beats, which are abbreviated PACs or PABs, and so PAC or PAB. And these are where you have extra contractions of or ectopic beats, okay? And these are irritable atrial muscle cells that are outside of the conduction pathways that are just causing some chaos. You can have atrial flutter, and this is where your atrial heart rate is about 160 to 350 beats per minute, and the AV node delays the conduction, which makes the ventricular rate slower. You also have AFib, and this is where you have a rate of over 350 beats per minute, and this causes the pooling of blood in the atria. And whenever you pool blood, it has a chance to coagulate and clot, so no fun. And so then that can cause a thrombus, which would be a blood clot, and then you can throw one out and you can cause a stroke. Don't ask me how I know this, guys. I had a stroke last year because of this. Okay. Anyway, what about heart blocks? We can have conduction that's excessively delayed or stopped at the AV node or the bundle of His. You can have a first-degree block, a second-degree block, or a third-degree block. The first-degree block is the conduction delay between the atrial and ventricular contractions. You can have a second-degree block, and this is where the third atrial beat is dropped at the AV node. And then you can have a third-degree block, which is no transmission from atria to the ventricles. You can have ventricular conduction abnormalities, and this is where you have a bundle branch block, and this interferes with the conduction in one of the bundle branches. You can have ventricular tachycardia, and this is likely to reduce cardiac output as reduced diastole occurs. This is what I get. You have ventricular fibrillation, and this is where muscle fibers contract independently and rapidly. The cardiac standstill occurs if it's not treated immediately. And then also you have premature ventricular contractions, which are PVCs. Also have these. So much fun, guys. Welcome to my life. All right, and then you also have additional beats from the ventricular muscle cell or ectopic pacemaker, and this may lead to ventricular fibrillation. So here is a fun summary table of some of your cardiac dysrhythmias, and these are found on page 244 in your book on table 12.2. And so this is a great little summary. It would be suggested that you can make these into flashcards because this is great little summaries that you need to know, or at least dog-ear the page. So how do we treat these cardiac dysrhythmias? Well, the cause needs to be determined first, and then we need to treat it. So you can use antidysrhythmic drugs, and these are effective in many cases. You can have SA nodal problems or total heart blockage that can require the insertion of a pacemaker. Then you also can have the defibrillator option, and this may be implanted for the conversion of the ventricular fibrillation. So again, I have one. I showed you my scar. You can't really see it very well, but I have one right under here. It's pacemaker, defibrillator, both 2 lead. So much fun. So what about cardiac arrest? This is when you have the cessation or the stopping of all heart activity, and there are no conductions of impulses. And it shows you have a flat ECG. There are many reasons that these can occur, including excessive vagal nerve stimulation, potassium imbalance, cardiogenic shock, drug toxicity, insufficient oxygen, respiratory arrest, as well as a blow, like, thump to the heart. So moving on to congestive heart failure. This is what happens, this is on page 245, when the heart is unable to pump out sufficient blood to be able to meet the metabolic demands of the body. And this is usually a complication of another cardiopulmonary condition, and this may involve a combination of different factors. You have various compensation mechanisms that your body's really smart, and it really tries very hard to keep you alive, right? And so this is one of the things, like, it comes up with compensatory mechanisms to maintain that cardiac output, and some of these can often aggravate the condition. So when the heart cannot maintain pumping capability, then the cardiac output or stroke volume is going to decrease. Then because of this, less blood is going to reach the various organs. And then when your cells aren't getting blood, then they're going to have decreased function. Then you also can have fatigue and lethargy, and you can also have a mild acidosis that develops. Okay. Um, Also, backup and congestion may develop as coronary demands for oxygen and glucose are not met, and then output from the ventricles is less than the inflow of the blood. And congestion in venous circulation can drain into the affected side of the heart. So here is a summary table of congestive heart failure. This is on page 246 of your book, and this is figure 12.20. And so basically up here, it has an example of myocardial infarction of the left ventricle, and this can lead to a loss of heart muscle, which can then lead to decreased cardiac output. So then you can have compensation mechanisms that are activated, including stimulating sympathetic nervous system, which leads to vasoconstriction and increased resistance to the left ventricle, increased heart rate and force, which is increased work for the heart. It can also stimulate your renin secretion, which leads to activation of the angiotensin vasoconstriction pathways. It can stimulate down here aldosterone secretions, which increases sodium and water retention, increased blood volume, and increased work for the heart. Right, and then how do we treat it? These are different ways that we can treat it. We're alpha adrenergic drugs, vasodilators, calcium blockers, beta blockers, digoxin, diuretics, and ACE inhibitors, right? And all of these are compensations to maintain cardiac output for a time. And then you can see that it can keep circulating. Then if we have heart muscle that weakens, then this can cause the left-sided congestive heart failure, which is where the left ventricle does not fill completely. The left ventricle does not empty completely, and that can cause to decrease cardiac output. Then the blood can back up in the pulmonary circulation, and this can lead to pulmonary congestion. This can also lead to increased resistance for the right ventricle, where the right ventricle is going to weaken and cannot fully empty. And then the blood will back up here in the systemic circulation, and this can cause edema in the legs and in the digestive system. Okay, so all of these things can happen, and it can be a repeating pathway, and hopefully we can catch it and treat it so that it doesn't continue to go downhill. So what about the effects of congestive heart failure? And so this is the left-sided congestive heart failure. This is on page 248 in your book, part A. And so over here in 1, the left ventricle weakens and it cannot empty. And so then this leads to a decreased cardiac output that occurs in the whole system. Then because we have decreased output, then we have decreased renal blood flow, which is going to stimulate that renal angiotensin and aldosterone secretion. That leads to a backup of blood in the pulmonary vein, and then that can lead to high pressure in the pulmonary capillaries that leads to the pulmonary congestion or edema. We also have right-sided congestive heart failure, and this is where the right ventricle weakens and it cannot empty. And because of this, the decreased cardiac output occurs to the system. And then the decreased renal blood flow stimulates the renal angiotensin and aldosterone secretions down here. And then that causes a backup of blood into the systemic circulation, which specifically the vena cava, and then, which is the big vein, right? I love the words. Okay. And then you have increased venous pressure that results in edema in the legs and the liver and the abdominal organs here. And then all of that coming together can lead to very high venous pressure, and this can cause the distended neck and vein in the cerebral edema. So that's like one of the things they'll do is they'll have you turn to the left and kind of cock your head, and they'll look for your carotid artery if it's swollen or really pulsating. All right, so signs and symptoms. You have forward effects, which are similar with failure on either sides, and this would include decreased blood supply to the tissues and general hypoxia. You also have fatigue and weakness, and dyspnea and shortness of breath. You can also have compensatory mechanisms, which you try to do to compensate for things, and this can cause tachycardia, which is that racing heart rate. You can have cutaneous and visceral vasoconstriction, and then also daytime oliguria. I realize I'm on video and I just made a face at my kiddo. I totally just stuck my tongue out at you and I'm recording myself. All right. So what about backup effects of the left-sided failure? Well, this can be related to pulmonary congestion. This can lead to dyspnea and orthopnea, which is going to be developing as fluid accumulates in the lungs. This can lead to a cough, which is associated with fluid. It's just irritating the respiratory passages. You can have the proximal nocturnal dyspnea, and this would be where you have indicating the presence of acute pulmonary edema that can occur. Usually this develops during sleep, and excess fluid in the lungs frequently leads to infections such as pneumonia. The signs of right-sided failure and systemic backup, it's dependent on edema in the feet, the legs, or your butt. The increased pressure in the jugular veins is going to lead to distension. You can have hepatomegaly or splenomegaly, and this is where you have digestive disturbances that can occur. You can also have ascites, and this is where you have a complication when the fluid is going to be accumulating in the peritoneal cavity, and this is seen by marked abdominal distension. And then also you can have acute right-sided failure, and this is causing flushed face, distended neck veins, headache, and visual disturbances. The ascites, I actually had a friend, met her in the ER, and she had this, and it looked like she was, like, if you could be 12 months pregnant, obviously you can't, but it looked like that. I mean, she was this, like, beanpole of a person, but her belly was so huge, and it was all from ascites. It was insane. Here is a summary figure of your congestive heart failure, and this is figure 12.3 book. And so then it's going to be comparing your left and your right-sided congestive heart failure, and this is on page 247. So again, a great flashcard summary table. So what about young kids with congestive heart failure? Well, this is often secondary to congenital heart disease. This can manifest itself by having feeding difficulties. This can be oftentimes the first sign. And also kids might have a failure to gain weight or meet developmental guidelines. They also have short sleep periods, tripod position to play. They can exhibit cough, rapid grunting respirations, flared nostrils, as well as wheezing, and radiographs can show the cardiomegaly. And arterial blood glasses are used to measure your levels of oxygen, hypoxia. So, what about your congenital heart defects? So the young kids is on page 249. If you guys wanted to follow along, then the congenital heart defects are on page 250. So you have your cardiac abnormalities, and these are structural defects in the heart that develop during the first 8 weeks of embryonic life. And congenital heart diseases include valvular defects, septal defects. These are detected by the presence of heart murmurs. And if they're untreated, the child may develop heart failure, and they may be cyanotic or acyanotic depending on the direction of the shunting in the vasculature. Large defects can cause pallor, tachycardia, which can occur with very rapid sleeping pulse and frequent pulse deficit. You can have dyspnea and exertion, the squatting position where the toddlers and older children, and this appears to modify the blood flow and it's more comfortable for them. And so everyone will do things to make themselves as comfortable as they can be. Also, they can have clubbed fingers, and they can show an intolerance for exercise and exposure to cold weather. You can also have delayed growth and development in these children. So diagnostic tests. So severe deficits are often diagnosed at birth when they do the once over, right? But others might not be detected for some time. And so we have a couple different examination techniques. Some of them are very similar to what we do in adults: radiography, diagnostic imaging, the cardiac caths, the echocardiograms, and the electrocardiograms, and also looking for surgical repairs if there's any holes that aren't going to close on their own. All right, so what about inflammation? Inflammation and infection of the heart. Um, so basically, this is when we're going to talk a little bit about the diseases that can cause problems. So this would be on page 255 of your book. So rheumatic fever and rheumatic heart disease. So, rheumatic fever is an acute systemic inflammatory condition, and this may result from abnormal immune reactions. And these can occur a few weeks after an untreated infection. And usually, this is group A beta hemolytic streptococcus that occurs or that causes this. It involves the heart as well as joints, and it usually occurs in kids aged 5 to 15 years. And there are long term effects. There's rheumatic heart disease. My husband's singing in the other room. Sorry. And these may be complicated by I'm sorry, infective endocarditis and heart failure in older adults. You have the acute stage, which would be caused by the inflammation of the heart, pericarditis, myocarditis, and endocarditis, as well as incompetent heart valves. You also have other sites of inflammation, including your large joints, the erythema marginatum, non-tender subcutaneous nodules, and involuntary jerky movements of the face, legs, and arms. Some signs and symptoms could be low-grade fever, leukocytosis, malaise, anorexia and fatigue, tachycardia, heart murmurs, epistaxis, and abnormal pain may be present. He's seriously jamming out in there. It's hysterical. All right, on page 256, this is figure 12.28. This is showing a rheumatic heart disease. And so this is an acute rheumatic mitral valvulitis. And so the red irritated area where it be, this is going to be the stenosis or the closing of that. So this is the mitral valve stenosis. Note the narrow valve opening. So if we go back to this one, we have nice wide openings, where in this one it's very truncated, right? It's stenotic. It's like almost closed, right? Signs and symptoms of this could be low-grade fever, leukocytosis, malaise, anorexia, fatigue, tachycardia, right? It's kind of like the same signs and symptoms. Diagnostic tests, elevated serum antibody levels, heart function tests, and electrocardiography, as well as an ASO titer. Treatment could be prophylactic antibacterial agents as well as anti-inflammatory agents just to try to keep things under control before they go crazy. This is the development of rheumatic fever and rheumatic heart disease. And so this is figure 12.27 in your book on page 220 or 255. And so up here you have your antecedent infection, which is where you have your group A beta hemolytic streptococcus that can hopefully you recover. But if not, or you do recover, and then you form antibodies, and then those antibody collagen reactions can occur, and then that can cause inflammation in the heart, which can lead to pericarditis or an effusion, endocarditis with valve damage, or myocarditis with arrhythmias. All of these can lead to the formation of scar tissue, which can cause the loss of valve functions and arrhythmia, therefore leading to rheumatic heart disease. What about vascular disorders? Well, if we're looking at arterial diseases and hypertension, this is high blood pressure. And so this is on page 258. High blood pressure is common. This may occur in any age group, and it is more common in individuals of African ancestry. And sometimes this is classified as systolic or diastolic. Primary is going to be the essential hypertension, where the blood pressure is consistently above 140 over 90 millimeters of mercury, and this can be adjusted for age. You have an increase in the arterial vasoconstriction, and over a long period of time, you can have damage to the arterial walls. You can also have blood supplies that are involved in the areas reduced, and you can have ischemia and necrosis of tissues with loss of function. Secondary hypertension, this can result from renal or endocrine disease. You can have pheochromocytoma, which is a benign tumor of the adrenal medulla. This can cause underlying problems that have to be retreated in order to reduce that blood pressure. You can also have malignant or resistant hypertension, and this is uncontrollable, severe, and rapidly progressive forms that have many complications that occur with them, and the diastolic pressure is extremely high. Here is a nice schematic. I almost said schematogram. All right, on page 259, this is figure 12.30, and this is again the development of hypertension. And so basically you have increased blood pressure that can lead to damage to the retinal blood vessels causing blindness. You can have damage to the arterial walls leading to arterial sclerosis. You can have damage to the cerebral arteries, which can cause a stroke. You can have increased workloads for the heart that can cause left-sided congestive heart failure. This can lead to systemic vasoconstriction. You can have damage to the renal blood vessels, which can lead to either decreased blood flow to the kidney or systemic vasoconstriction. The systemic vasoconstriction can lead, again, to the decreased blood flow of the kidney and increased renin secretion. This decreased blood flow can also be caused by nephrosclerosis as well as diabetic neuropathy. And then the increased renin secretion can lead to systemic vasoconstriction or aldosterone secretion. The systemic vasoconstriction can lead to increased peripheral resistance, where the aldosterone secretion can lead to increased blood volume, and these again can continue to cause increased blood pressure. So you can see that it can be a vicious cycle. So areas that are most frequently damaged by hypertension include the kidneys, the heart, the brain, and the retina in your eyeballs, right? Predisposing factors include incidences that increase with age, men that are affected more frequently and severely, incidences in women, which increases after middle age, genetic factors, salt intake, excessive alcohol intake, obesity, smoking, or prolonged or recurrent stress. So what about the effects of uncontrolled hypertension? This is figure 12.31 on page 260. And so in your brain, this can lead to cerebral aneurysm or a hemorrhagic CVA stroke. It can lead to arterial sclerosis. It can lead to problems with your heart, including congestive heart failure, arteriosclerosis, angina, or MIs, so myocardial infarctions. It can cause damage to your kidneys, including nephrosclerosis and chronic renal failure. In your eyes, it can cause retinoplasty, which is arterial damage, and microaneurysms and ruptures. And it can have effects on your blood pressure, including a persistent elevation. Hypertension is frequently asymptomatic in early stages, and the initial signs are vague and nonspecific. These include fatigue, malaise, and sometimes morning occipital headaches, right? So like bottom part of your brain. Essential hypertension is treated in steps. First one being lifestyle changes, reduction in how much salt you eat, weight reduction, reduction in stress, as well as potentially pharmacologic drugs, which would be diuretics, your ACE inhibitors, or your drug combinations. What about peripheral artery disease and arteriosclerosis? This is on page 261. Basically, this is a disease in the arteries outside of the heart, and this is increased in incidences with diabetes. And the most common sites include the abdominal aorta, the carotid arteries, and the femoral and iliac arteries. You have diagnostic tests that can occur, and this would be like looking at blood flow that's assessed by the Doppler studies with the echoes, and arteriography. You can have plethysmotic measures on the size of the limbs and the blood volumes in the organs and the tissues as well. What about signs and symptoms? Increasing fatigue and weakness in the legs, intermittent claudication or leg pain associated with exercise that can be caused by muscle ischemia, sensory impairment such as tingling, burning, or numbness, peripheral pulses distal to the occlusion become weak, and then also the appearance of your skin. And so marked pallor or cyanosis, the skin can be dry and hairless, and the toenails can be thick and hard. So how do we treat this? Well, maintain the control of the blood glucose levels, reduce body mass index, so your BMI scale, reduce the serum cholesterol level, Platelet inhibitors or anticoagulant medications, stop smoking, increase your activity and exercise, maintain dependent positions for legs, the peripheral vasodilators, observe skin for breakdown and treat it promptly. And if gangrene develops, then amputation is required so it doesn't spread systemically and kill you. Aortic aneurysms, this is started on page 261. This is localized dilation and weakening of the arterial wall. This develops from a defect in the medial layer, and there are different shapes of aneurysms. You have saccular, which is bulging wall on the side. You have fusiform, and this is where you have circumferential dilation that runs along this section of the artery. You also have dissecting aneurysm, and this is what develops when there is a tear in the intima of the wall and the blood continues to dissect or separate tissue. And so this is figure 12.32 on page 262 of your book, and these show the different types of aortic aneurysms, the fusiform, the saccular, or the dissecting one that bifurcates. So what is the etiology? Arteriosclerosis, trauma, syphilis, or other infections, as well as congenital defects are the most common causes of aneurysms. Signs and symptoms are a bruit, which is a blowing sound, and this may be heard on auscultation. The pulse may be felt on palpation of the abdomen. There's frequently, they are asymptomatic until they become large or they do rupture, and the rupture may lead to moderate bleeding, but usually it causes severe hemorrhaging and death. So aneurysms are not very fun. Diagnostic tests include radiography, ultrasound, as well as CT scanning and MRI. Here is a picture of an abdominal aortogram, and this again is on page 262. This is figure 12.32 D, and so this is the abdominal aortogram that's showing a secular abdominal aneurysm at the arrowhead here. And external view for abdominal aortic aneurysm, arrow marking the rupture. Okay. And finally, how do we treat it? Well, maintain blood pressure at a normal level. Try to prevent sudden elevations that can be caused by exertion. Try to prevent stress, coughing, or constipation. And also quickly try to do surgical repair. All right, we'll see you in class, guys. Thanks.